Hit the subscribe button or visit us at auau.auanet.org.
Good evening and welcome to AUA's summer school webinar, Integrating Care for Oncology Patients, Establishing a Multidisciplinary Oncology Clinic with Advanced Therapeutics. I thank you for joining us, but before we get started, I'd like to go over a couple of things to let you know how to participate in today's event. The AUA is accredited by ACCME and designates this Internet Live activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts have from the presentation have been made to you for your review. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations on CME credit will be administered electronically on AUA University immediately following the webinar. As AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both content and format of this webinar. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view Faculty and Education Council disclosures. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. We do hope that you can actively participate as you connect and learn from each other during the course. Due to the size of the audience, all participants will be in listen-only mode, but we encourage you to use your questions pane to ask questions throughout the webinar for a Q&A session at the end of the webinar. We also encourage you to get social with the AUA, so please share any highlights from your this program with the global urology community by tagging Amir Urological and using the hashtag AUA Virtual EXP. You can also access course evaluation credit claim and your CME certificate by visiting AUA University and using a keyword that we provided to you at the end of this webinar. For our acknowledgements, this educational series is supported by independent educational grants from Astellas, AstraZeneca, Bristol Myers Squibb, Genentech, Merck, Pfizer, Inc., and Sanofi Genzyme. So now Dr. Stratton, our esteemed course director, will come on and we will have a brief knowledge assessment.
Thank you. Welcome to this webinar. Before we begin the live discussion, we'd like you to participate in a brief knowledge assessment. At the close of the webinar, we'll have a follow-up assessment using the same questions. The results of this assessment helps the AUA measure the educational effectiveness of this live educational activity and will help us plan and develop future activities. Here's our first question. A multidisciplinary treatment team may include which of the following: advanced practice provider, radiation oncologist, pain management, dietitian, or all of the above?
Please key in your answer now. Okay. Some people are voting. Okay, keep on voting. We've got just a few more seconds left to go. I'll close the poll. We can go to question 2. Okay. All right, I'm going to go ahead and close this poll and we will move to question 2.
Question 2, recently approved pembrolizumab for BCG unresponsive, high-risk, non-muscle invasive bladder cancer requires presence of the following: PD-L1 positive status.
Sorry.
Let's see. Trying to get that back.
There we go.
Hard to answer a question you can't see. Stage T1, carcinoma in situ with or without papillary tumors, failed treatment with gemcitabine, or none of the above.
Please key in your answer now. Okay, we'll just give you another few seconds. Okay, we're going to go ahead and close this poll. Come to question 3.
Question 3, which is not critical when considering the role of upfront cytoreductive nephrectomy? The IMDC risk groups, the MDA surgical criteria, burden of the tumor.
I do apologize, not sure why it keeps doing that.
The ability to do minimally invasive surgery, or the urgency of some systemic therapy.
Okay, go ahead and watch this. Please key in your answer now. Okay. Okay, I'm going to go ahead and close this poll. Go to question number 4.
Question number 4, germline genetic testing is recommended for prostate cancer patients with high-risk disease, very high-risk disease, regional spread, metastatic disease, or all of the above.
Go ahead and please key in your answer now. Okay, go ahead and close this. Okay, last question.
The last question is a 57-year-old man who previously underwent prostatectomy and adjuvant radiation therapy and then was started on androgen deprivation therapy at the time of PSA recurrence. He now has a rising PSA with a 3-month doubling time, with a doubling time of 3 months, and negative imaging with castrate level testosterone. Which of the following is most appropriate? He should undergo repeat imaging in 6 months. Bicalutamide should be initiated for M0 or CRPC. Enzalutamide or apalutamide should be initiated, or ketoconazole could be considered as treatment for M0 CRPC.
Okay. Last one. Please key in your answer now. Okay, looks like nearly all of you have voted, so we're going to go ahead and close this poll, and I think we're all set there. So thank you very much for participating. And I'm going to turn it over right now to Dr. Stratton.
Thank you, and thank you again for attending this webinar, Integrating Care for Oncology Patients, Establishing a Multidisciplinary Oncology Clinic with Advanced Therapeutics. Here are our learning objectives. And then I'd like to quickly introduce our faculty. We have Alicia Morgans, an Associate Professor of Medical Oncology at Northwestern University, Kelvin Moses, an associate professor at Vanderbilt University, and Brian Shook, associate professor of urology at UCLA. I'm Kelly Stratton. I'm an associate professor at the University of Oklahoma. I'll start with a brief introduction of multidisciplinary oncology clinics. The objectives of this brief introduction are just to describe the components of a multidisciplinary clinic, examine some of the structures for these clinics, and then talk a little bit about the potential benefits of having advanced practice providers in your multidisciplinary clinic. So, oncology care has been evolving tremendously over the past decade, and there's an interest in increasing the utilization of multidisciplinary care as treatment programs have become more complicated and involved multiple different modalities of treatment. And this comes from the ASCO 2017 State of Cancer Care in America, really presenting a call to deliver multidisciplinary cancer care across all different cancer settings as a marker of quality and as a potential benefit to patients. Multidisciplinary care is recognized as improved patient care. Healthcare systems and governments across the world mandate multidisciplinary care as a way to ensure patients receive quality care. And there are many benefits to this. Recognizing that multidisciplinary care is not always easy, and that's part of the reason that we're here tonight is to talk about all the different potential benefits and strategies for implementing multidisciplinary care. Certainly, we know that oncology care providers are facing decreased reimbursement, increasing workloads, an increasingly complex treatment plan, and the challenges of presenting patients with personalized treatments. And so multidisciplinary care is one of the best ways to implement these treatment plans. There are several strategies for setting up a multidisciplinary clinic. One way is to just have all the specialists in one clinical space. That's the all-in-one approach. It's one of the most demanding as far as logistics. It's difficult to have all the different representative members in one spot. And so for some places, a virtual clinic where providers come, where providers see patients in their clinic separated by different locations, sometimes on the same day, sometimes on different days. But the patients are able to see multiple different specialists, and together they form a treatment plan that benefits the patient. In these cases, tumor boards can be a great place to bring together the specialists to review cases, talk about new treatment opportunities, and consider clinical trials as well. For any one particular provider, it can be very difficult to carry the entire burden of multidisciplinary care, and having advanced practice providers can be very helpful to share some of that workload. Advanced practice providers, including nurse practitioners and physician assistants, can help by providing order entry, medical management, wound care, patient management, and also collaboration with primary care providers. In an ASCO survey of surgical oncologists, up to 85% of them used advanced practice providers, either together with them in clinic or as independent providers. So in conclusion, urologists are a central figure and really a gatekeeper of cancer patients. Utilization of multidisciplinary clinics allows multiple specialties to help provide treatment for these patients. There are new therapeutic opportunities, and multidisciplinary clinics can help provide those treatments for patients. Using advanced practice providers can help us carry the workload and take care of patients efficiently. I'd now like to turn the presentation over to my colleague, Alicia Morgans, to talk about a multidisciplinary approach to prostate cancer.
Thank you so much, Kelly, and thank you to everyone who's attending tonight. We are so excited to have you here, and we'll talk now about multidisciplinary opportunities in prostate cancer care. These are my disclosures. And the outline will speak first about metastatic hormone-sensitive disease, and then we'll move on to non-metastatic CRPC. We'll move then on to complications of ADT and specifically focus on bone health, which I think is an under-recognized and important area for us to address as we're caring for these prostate cancer patients. And then we'll talk about new guidelines and ways that we can ensure that our patients have guideline-adherent germline genetic testing for their prostate cancer. And we'll wrap up at the end with a summary. So first, we can talk about multidisciplinary opportunities in metastatic hormone-sensitive or metastatic castrate-sensitive prostate cancer. I think that as we think about any treatment in this disease space, we should definitely recognize that whatever we choose in terms of intensification in combination with ADT will affect our downstream treatment effects, and that really partnering between urologists, medical oncologists, and as we'll talk about in a moment, radiation oncologists as well, is going to be an important way for us to really optimize the outcomes for our patients. Additionally, understanding this landscape helps us recognize why it's important for us to think about germline and somatic genetic testing for our patients, and we'll address that in a few moments. When we think about things like pembrolizumab and the PARP inhibitors, olaparib and rucaparib, which are recently approved agents as of May of 2020. So first, I think it's important for us to remember where we came from. And our first study thinking about multidisciplinary activity in the metastatic hormone-sensitive or castrate-sensitive prostate cancer setting was really the CHARTED study, which came out via oral presentation at ASCO in 2014 and then was published in the New England Journal in 2015 by Dr. Sweeney and colleagues. It was an ECOG study that looked at ADT versus ADT plus docetaxel for 6 cycles for patients who had metastatic hormone-sensitive disease. This disease could have recurred after initial treatment of a local primary and then recurrence, or it could have been de novo metastatic disease. But that's important to remember as we think about the application of this particular data. In that setting, we found that there was an improvement in overall survival with chemohormonal therapy, so docetaxel plus ADT versus ADT alone. And it was not just an improvement in survival, but also an improvement by 12 months of quality of life as well. This was really replicated in the STAMPEDE trial, which importantly was predominantly de novo metastatic patients, but also we found that in that setting, patients seemed to benefit across the board from treatment with docetaxel for 6 cycles plus ADT versus ADT alone. So this was really our first introduction to intensification therapy that demonstrated that ADT alone was not enough, at least for patients who were able and fit to receive chemotherapy. Further work demonstrated that abiraterone was also going to be an option in this space. As we can see on the left in the survival curve, this is the latitude data published by Fazazi and colleagues back in 2017. And we see that the combination of abiraterone plus ADT versus ADT alone actually demonstrated a very clear survival benefit with that combination therapy versus ADT alone. And we can see the hazard ratio here demonstrating a 38% reduction in the rate of mortality. On the right, we can actually see another STAMPEDE arm. This was metastatic hormone-sensitive prostate cancer patients who were treated with ADT plus abiraterone versus ADT alone. And again, we saw a very similar survival advantage in this population. So this consistently demonstrated that abiraterone in combination with ADT was also going to benefit our patients. As we think about this from a multidisciplinary perspective, really medical oncologists in the past have kind of led the way in terms of chemotherapy. Abiraterone has been an agent that has been used by urologists and medical oncologists in the metastatic castration-sensitive or resistant space. And so as we think about how to choose, sometimes this, I think, could be a reason. If you're a urologist, perhaps we'd want to use abiraterone, or perhaps if you're a medical oncologist, we'd want to use docetaxel. How do we choose besides that? Because that's not a great reason to choose one therapy over another. Well, we actually had the opportunity to understand this decision in STAMPEDE. So in Stampede, about 560 patients were contemporaneously randomized to treatment with chemohormonal therapy with ADT plus 6 cycles of docetaxel versus ADT plus abiraterone. And they were followed for survival among other endpoints. As we can see here in this unplanned, unspecified, or not pre-specified analysis, there was actually no difference in overall survival between those two treatment arms. And we can see those survival curves completely overlap. Although there were differences in PSA progression and even in radiographic progression, perhaps, there was no difference in overall survival. So this leads me to conclude that we can actually choose either of these options as long as we talk to patients and think about their preferences and their wishes as they choose one agent over another, perhaps in this metastatic hormone-sensitive setting. But clearly, an intensification strategy of ADT plus something must be used. This became even more clear when we saw the Titan data, which was published a few years later. This demonstrated the use of apalutamide, so another androgen receptor antagonist that was used in combination with ADT versus ADT alone in a metastatic hormone-sensitive setting. As we can see on the left, radiographic progression-free survival was improved with the combination of ADT plus apalutamide versus ADT alone, as was overall survival with this combination strategy. This was also the case for enzalutamide, which was reported very closely thereafter. Enzalutamide plus ADT was associated with a survival benefit as compared to ADT alone. And actually, it wasn't just ADT alone in the ENZAMET trial. It was ADT plus nilutamide, flutamide, or bicalutamide. So quite an active control arm of ADT plus a non-steroidal anti-androgen versus ADT plus enzalutamide. And still, we saw a survival benefit. Importantly, in the ENZAMET trial, there were actually a large portion of patients who received the combination of ADT plus docetaxel plus enzalutamide versus ADT and docetaxel alone. What we can see in the top two curves, which is progression-free survival on the left and overall survival on the right, when we had the triple combination of ADT plus docetaxel plus enzalutamide versus ADT plus docetaxel alone, there was a progression-free survival benefit, as we see on the left, but in that upper figure on the right, there was no difference in overall survival with the addition of enzalutamide to ADT plus docetaxel versus ADT plus docetaxel alone. This data is very early, and so there are hypotheses that if we continue to follow this out, we will see a benefit for the triple therapy. But in the short term, at least, from the data that we have, there is no clear benefit to triple therapy, ADT, docetaxel, and an anti-androgen as compared to ADT and docetaxel alone. On the lower two curves, we can see patients who were untreated with docetaxel, very clear benefit to ADT plus enzalutamide versus enzalutamide alone in progression-free survival on the left and in overall survival on the right. So this leads us to the NCCN and also AUA updated guidelines for advanced disease that have come out, demonstrating that our category 1 opportunities for treatment of these patients includes combinations of ADT plus an anti-androgen or an androgen receptor-directed therapy like abiraterone, or we can also see ADT plus docetaxel in this setting, all being category 1 opportunities for us to really get the best for our patients, not only in disease control, but also in quality of life. ADT alone, no longer really a clear option for our patients unless there are competing risks or other comorbidities that make combination therapy not an option. And so really, from a multidisciplinary perspective, this makes a lot of sense. We need to talk with our colleagues about how to best deliver these therapies if we ourselves, as urologists or medical oncologists, do not feel comfortable with that combination treatment approach. Additionally, as we saw in Stampede, we can also combine radiation to try to improve outcomes for patients as well. And this is radiation of the primary. What we saw in this study, which was again all metastatic hormone-sensitive patients, predominantly de novo metastatic, who were randomized to treatment with ADT plus radiation to the primary versus ADT alone, there initially was no difference, and actually was no difference in the overall assessment of this approach, ADT plus radiation to the primary versus ADT alone. But importantly, one of the endpoints that was identified prior to analysis, but not prior to writing the protocol, and was added as an amendment later, again, prior to analysis, was the investigators' hunch that perhaps if they separated patients into low volume metastatic disease and high volume metastatic disease, there may be a difference in terms of the benefit of radiation to the primary. As we can see on the left, for those patients who had low volume disease, standard of care ADT plus radiation to the primary was associated with a survival benefit as compared to ADT alone. However, in high volume or high burden patients, which we can see on the right, there was no benefit to radiating the primary. So really in these low volume patients, making sure that we intensify systemic therapy as well as consider the opportunity to use radiation to the primary is going to be critical and is definitely a point of multidisciplinary teamwork. So for metastatic hormone-sensitive disease, we now know that there are multiple choices for combination systemic therapy. For patients who have de novo metastatic disease, we know that this is a group that may benefit most from chemohormonal therapy, as well as those patients who have high volume hormone-sensitive disease. And many patients actually like the idea of having 6 cycles and then being done with therapies other than their injection ADT. Additionally, copay issues may push patients in the direction of having chemohormonal therapy up front and other patient preferences. So it's important for us to ask as a multidisciplinary team what patients as part of that team really want to do. Otherwise, other metastatic patients, metastatic hormone sensitive, should consider either abiraterone, apalutamide, or enzalutamide in combination with their standard ADT to really enhance the benefit of that intensification therapy and ensure that they have the best disease control as well as quality of life outcomes. Treatment of the primary tumor with radiation in low volume disease should definitely be considered and should be discussed, whether that's the urologist then referring to radiation oncology or looping in the medical oncologist as well. Everybody can really comment on that and hopefully get the best outcomes for the patient, of course. And multidisciplinary teams can really work together to guide the personalized choices of patients as they interject their own preferences in those decisions. What about multidisciplinary care in non-metastatic CRPC? This is an area that's really been exploding in the last few years, and we know that choosing patients who may be able to benefit most is one of the most critical parts of this. We can definitely identify patients with a PSA doubling time of 10 months or less as being a patient population that can benefit most. And we saw that there were 3 studies that looked at androgen receptor antagonists in the metastasis-free survival outcomes of patients who had non-metastatic CRPC. Spartan, Prosper, and Aramis were phase 3 trials that looked at these patients with PSA doubling times of 10 months or less and randomized them to treatment with ADT versus ADT plus apalutamide, enzalutamide, or darolutamide. We saw that each of these actually prolonged metastasis-free survival in all of these settings by 22 to 24 months. And this metastasis-free survival endpoint was novel to prostate cancer and was also a combination between developing metastases on conventional imaging or death from prostate cancer. We also saw in an updated analysis at ASCO this year that integrating these agents early when patients had non-metastatic CRPC versus their next progression point, which presumably would be the development of metastatic disease on conventional imaging, was associated actually with an improvement in overall survival. So even though many of the patients on the control arms of these studies actually received apalutamide, enzalutamide, or darolutamide at the point of progression, this was not sufficient to make up for the benefit that was provided when these drugs were integrated in the non-metastatic CRPC setting. So patient selection is going to be really important as we identify and think about these patients with a PSA doubling time of less than or equal to 10 months. But coordination of care between urology and medical oncology is going to be critical as we try to identify these patients and then ensure that they get the best systemic therapy necessary. Perhaps this can happen within your urology clinic, but again, identifying these patients can be challenging. Treatment of these patients with enzalutamide, apalutamide, or darolutamide can prolong metastasis-free and overall survival, and really identification of these patients is going to be critical. What about bone health? Well, we know that ADT exposure can increase the risk of fracture for patients, especially prolonged exposure to hormone deprivation and low testosterone can really increase the risk of fracture and the decrease of bone mineral density in our patients. So the NCCN and the National Osteoporosis Foundation, among other groups, have really supported the use of calcium, vitamin D in this setting, as well as thinking about getting DEXA scans to understand the bone mineral density of our patients, and then plugging this information along with other clinical and pathologic information into a FRAX calculator, the WHO's FRAX calculator, to understand the 10-year probability of hip fracture and major osteoporosis related fracture, to know if these patients should get additional pharmacologic therapy using denosumab or zoledronic acid or one of the other bisphosphonates to prevent these complications. And some of the increased risk items are listed here, including being elderly, use of alcohol, smoking, and exposure to steroids, as well as exposure to ADT. So we know that coordination of care between teams is going to be critical, and identifying who's going to own bone health is really important. And we know that the patients who are on ADT for longer than 2 years are going to be the most important to target. We also know that ensuring that metastatic CRPC patients get their up to monthly use of denosumab or zoledronic acid to prevent symptomatic skeletal events is critical, and is different than preventing fragility fractures in the hormone-sensitive population. And so we have to make sure that we as teams have plans to capture these patients, whether it's medical oncology, whether it's urology, or whether it's integration of advanced practice providers to really ensure bone health is really maintained in these patient populations. Finally, genetic testing is critical. The guidelines have been updated in the last few years to ensure that patients who have high risk and very high risk are consider genetic counseling, as well as consider germline genetic testing to look for familial syndromes of cancer inheritance. Additionally, patients who have regional disease and metastatic disease are recommended to undergo genetic counseling or to consider genetic testing overtly. So when we think about this from a multidisciplinary perspective, who on the team is going to own genetic counseling and genetic testing? Is it genetic counselors? Is it the urologist? Is it the medical oncologist? Is it someone else? And how do we ensure that workflow for our particular practice actually makes this happen? Many practices include urologists and medical oncologists who are doing the consenting and doing the testing on their own, and then sending patients who actually have identifiable DNA repair defects or other syndromic defects to genetic counselors for post-test counseling, which can be really helpful if we're doing a lot of patient care and there are many patients who need testing. But this model doesn't work for everyone, and some practices actually want to do pre-test counseling, which can work for you if that's the way that your practice flows. But we do need to understand where the genetic counselor fits in, and if a genetic counselor is not in the practice, how we can get genetic counseling through chat bots, or other ways through these testing agencies to try to get proper counseling for our patients and their families. So ultimately, multidisciplinary care opportunities span the continuum of prostate cancer, and engaging these multi-D teams can enhance disease-specific outcomes, including overall survival and metastasis-free survival, reduce morbidity and mortality, improve quality of life, especially when we're talking about things like bone health, and identify risk factors for family members to also improve their care when we're talking about things like germline genetic testing. And thank you so much for your time. And I'm going to now hand over the screen and the talk to Dr. Kelvin Moses, who's an associate professor of urology at Vanderbilt University.
Thank you, Alicia. I appreciate that. And thank you for everyone who is attending this presentation. I'll be presenting multidisciplinary care for metastatic castrate-resistant prostate cancer. This talk will be a logical follow-up to what Dr. Morgans has presented, as this is a more advanced version of the type of disease she was describing. You can see my disclosures here. Our objectives for this presentation: number one, to understand the clinical guidelines for immunotherapy in the form of sipuleucel-T in metastatic castrate-resistant prostate cancer. Secondly, discuss second-generation oral anti-androgens for mCRPC. Thirdly, to learn how to incorporate radium-223 therapy in the appropriate patient population. And then lastly, to develop a framework for multidisciplinary care of mCRPC patients based on the current AUA guidelines. The natural progression of prostate cancer pictured here shows that most men are diagnosed with localized prostate cancer and undergo some sort of primary therapy, either surgery or radiation with or without hormones. Unfortunately, a significant portion of these men will experience recurrence, and some will require androgen deprivation therapy to suppress the PSA and help prevent metastasis. Some men eventually will develop resistance to androgen deprivation and eventually develop metastasis, and these men will require advanced systemic therapy. To define castrate-resistant prostate cancer, we must know, number one, that patients are on adequate ADT and their serum testosterone is suppressed to less than 50 nanograms per deciliter. Additionally, patients need to have 3 consecutive rises in PSA, progression of pre-existing disease, or appearance of new metastases. I won't go over this entire chart, but the AUA has published guidelines for the management of CRPC, and another update is coming in May. We'll first talk about immunotherapy for metastatic castrate-resistant prostate cancer, starting with a clinical scenario. This patient is Mr. S, who is a 61-year-old Black man who presents with mCRPC. He initially had surgery in 2012, which showed Gleason 8 prostate cancer with a positive margin. His PSA did nadir, but became detectable 1 year later and rose up to 3.5. His staging at that time was negative. So he was started on androgen deprivation. His PSA remained undetectable until the next year when it rose to 5. He still was asymptomatic, and repeat imaging, including a bone scan, was performed. And as you can see here, there is a lumbar lesion consistent with metastatic disease. Therefore, under the AUA guidelines, he is index patient 2, which is an asymptomatic metastatic castrate-resistant prostate cancer who has not received prior docetaxel. Treatment options include abiraterone with prednisone, enzalutamide, Sipuleucel-T, and docetaxel. We'll discuss first Sipuleucel-T. This is FDA approved for men with asymptomatic metastatic castrate-resistant prostate cancer with reasonable life expectancy of at least 6 months. Some side effects of treatment include fever, chills, nausea, back pain, and infusion reaction. Rarely are stroke and thrombotic complications seen. The way this is usually described is men experience something like a flu shot type reaction. Poor candidates for Sipuleucel-T include patients with symptomatic disease, rapidly progressive disease, meaning their PSA doubling time is very short, those with limited life expectancy, and possibly those with majority visceral metastasis. Sipuleucel-T works almost like a vaccine in that the leukocytes are filtered from the patient's blood. This is then activated with GM-CSF and labeled with a fusion protein that is specific for the surface of prostate cancer cells. This is then reinfused back in the patient, which activates antigen-presenting cells and activates a cytokine response in order to kill prostate tumor cells. The pivotal trial for Sipuleucel-T was the IMPACT trial published 10 years ago, which showed a 22% reduction in the risk of death among those who received Sipuleucel-T versus those who received placebo. An absolute difference in approximately 4 months of additional survival was seen. Very importantly, though, men who receive Sipuleucel-T will not have a PSA or radiographic response associated with treatment. The IMPACT trial did show the 22% reduction in risk of death, and some prognostic factors associated with survival also included various factors, including PSA, performance status, and the presence of metastases. In order to determine the impact of the initial PSA at the initiation of treatment, the investigators divided the PSA values into quartiles. And what you can see here, the quartiles were broken up by PSA of less than 22, a PSA of 22 to 50, a PSA of 50 to 134, and a PSA of over 134. And what you see here is that the lowest value of PSA, being less than 22, had a 49% reduction in the risk of death, and this was significant. The next quartile, up to 50, did show a 26% reduction in death, but this was non-significant. But what the data indicates is that earlier treatment appears to have the greatest survival benefit. Now, some caveats to this study: this was not powered to detect a difference within groups, and the quartile groups were not randomized. So in order to get a better view of how Sipuleucel-T is being used in the real world and its effect, the investigators initiated what is called the PROCEED trial. This had over 1,900 patients who were enrolled, including 12% African American, to allow for adequate representation. And they analyzed white versus African American patients 2-to-1, matched by baseline PSA, and compared overall survival. As you can see here, the two groups are relatively well matched. There are some differences in performance status, the median hemoglobin, as well as the rate of prior local and chemotherapy. However, they were matched for PSA and age. And as you can see here, all of the men with a PSA in the first quartile, less than 7.5, had a significant improvement in overall survival. However, African American men had even greater survival of almost 17 months longer compared to white patients, and this was statistically significant. The next quartile of 7.5 to PSA of 26.8 also had a significant difference of over 14 months in survival compared to white patients. As was seen in the IMPACT trial, the higher PSA did not show significant difference between groups or overall in terms of survival. Our patient, Mr. S, received Sipuleucel-T, tolerated well, and his PSA remained stable for approximately 1 year and began to rise. He then had some development of bony disease as well as pelvic lymphadenopathy. He was still minimally symptomatic with some mild lower back pain. And so this takes us into discussion of second-line therapies. These include abiraterone acetate with prednisone, as well as enzalutamide. Dr. Morgan has already gone over abiraterone. Just briefly, it is approved for men before or after chemotherapy with metastatic CRPC. Common side effects include hypertension, hypokalemia, fatigue, and hyperglycemia. And patients who cannot tolerate steroids, such as brittle diabetics or those with rapidly progressive disease, are not good candidates for abiraterone. We'll briefly discuss the mechanism. Abiraterone blocks conversion of pregnenolone into its downstream targets, notably reducing testosterone. However, this does cause a rise in cortisol, which elevates ACTH, causing the side effects discussed before. The pivotal Cougar trial for abiraterone prior to chemotherapy showed a 25% reduction in the risk of death among men who received abiraterone versus prednisone alone. They also had a significant improvement in radiographic progression-free survival. Enzalutamide, also FDA approved for men with metastatic CRPC before and after chemotherapy. Common side effects include hypertension, fatigue, constipation, diarrhea, and rarely seizures. And because of that fact, there is a contraindication of men with a history of seizure receiving enzalutamide. Those who are with rapidly progressive disease are poor candidates for enzalutamide. Enzalutamide has multiple levels of action, which is different from bicalutamide. It does inhibit the androgen receptor, just like bicalutamide, but it also blocks introduction of the androgen receptor within the cell, and also within the nucleus to perform transcription. So multiple levels of blockade. The pivotal trial for prior to chemotherapy with enzalutamide is the PREVAIL trial, showing a 29% reduction in the risk of death and approximately 2-month improvement in overall survival. Our patient chose enzalutamide, and for 2 years, his PSA was undetectable. After approximately 24 months, his PSA rose to 2.5, and he switched to abiraterone for 6 months. However, his PSA continued to increase to 15. A repeat bone scan showed greater than 20 bony lesions, but stable lymphadenopathy. He is now complaining of rib, neck, and hip pain. So this takes us into our discussion of radium-223 for MCRPC primarily to the bone. This is within the AUA guidelines for index patient 3 who is symptomatic with bony disease. Radium-223 is in the same family as calcium on the periodic table and acts as a bone-seeking isotope. It complexes with hydroxyapatite and osteoblastic lesions and causes DNA double-stranded breaks by emitting high-energy alpha particles. Radium-223 has been approved before or after chemotherapy for MCRPC with symptomatic bone metastases. Side effects include nausea, vomiting, diarrhea, edema, bone marrow suppression, and rarely cytopenia. Poor candidates are patients with a history of bone marrow dysfunction or edema or high volume of visceral disease. The Alcimca trial was the pivotal trial for the approval of radium-223. Men received 6 treatments of radium-223 versus placebo. And as seen in the graph here, there's a 30% reduction in the risk of death for patients who receive radium-223 versus placebo. There was a recent study, phase 3B, showing, for concomitant therapy. This has been a level of interest. Overall median survival for the patients who received combination was 16 months versus 13 months for radium alone. However, 5% of patients experienced serious adverse events due to concomitant treatment. As Dr. Morgan also mentioned, germline and somatic testing should be performed in men with metastatic prostate cancer, and this can be performed with various tests, and there are several genes of interest, including the importance of BRCA1 and 2 and ATM in advanced prostate cancer. This is because PARP inhibitors have shown activity in patients who have a high level of DNA damage repair among these genes. It may be effective, PARP inhibitor therapy may be effective in metastatic CRPC when one of the DNA repair mutations is present. The 2 approved drugs in this space include olaparib and rucaparib for men with DNA damage repair mutations following androgen receptor-directed therapy and or taxane-based chemotherapy. Now, in regards to the multidisciplinary approach, the ingredients for a successful MCRPC clinic include urologists with an oncology focus, a medical oncologist, again with a genitourinary or prostate cancer focus, a mid-level advanced practice practitioner. This is someone who should be familiar with guidelines, can see stable patients, and also perform prescriptions. A specialty pharmacy is also very helpful. They can help with payment assistance for patients and mail medications directly to patients. Medical genetics is important for counseling and germline somatic testing. If you're going to perform Sipuleucel T, you need to have an apheresis location, and locally here in Nashville, we use the American Red Cross. Additionally, we need radiation oncology and nuclear medicine on our team for site-directed therapy. So in summary, patients with MCRPC have several options for treatment that are relatively well tolerated, although optimal sequence has not been determined. We should consider early utilization of Sipuleucel T, particularly in Black men, due to the improved survival benefit versus later stage disease. There are no existing data regarding efficacy of enzalutamide versus abiraterone as a first oral therapy, and therefore treatment decisions should be made in concert with the patient. Radium-223 does improve survival in men with bone-predominant disease and can safely be used in combination with either enzalutamide or abiraterone. And I'll be turning over the talk to Brian Shook for his portion of the presentation.
Okay, thanks, Kelvin. Appreciate it. So we'll be talking about some of the updates in kidney cancer and how we can potentially integrate some of these new novel treatment strategies in the context of multidisciplinary management. I run our multidisciplinary program at At UCLA, we have a program with our medical oncologist and actually a radiation oncologist, and we still play, urology plays an important role in all stages of disease. So a brief outline. So first, starting off with the micrometastatic disease setting, we obviously operate on a lot of patients who have high-risk disease, and clearly they have probably some micrometastatic disease which has escaped. These tumors have lots of shedding, and we know who these patients are, and we have historically had little we could do about it. But patients with high-level tumor thrombosis, extending deep up into the chest, or those with really invasion into other organs like the liver, these patients recur often, they recur early, and clearly there's something that we have really an unmet need in this field to kind of integrate medications earlier in our disease stage. And urologists are uniquely positioned to be involved in lots of these treatments, especially since patients who do not have metastatic disease already see the urologist, and we potentially have the ability to administer some of these agents to avoid, hopefully, development of metastatic disease. Well, how have we done so far to date? Well, there's been lots of therapies. These continue to get updated. Basically, anything which has been FDA approved for metastatic disease, we've tried to introduce earlier. And the current era of targeted agents really has been proven to be not very successful in trying to improve outcome with this disease. Agents such as sorafenib and Sutent, Pazopanib, Axitinib have all been really disappointing. These trials have a little bit differences in who they consider high risk, and also the histologies. Most of these are predominantly clear cell, some are only clear cell. But the risk varies in some trials, such as ASSURE having some T1Bs, other trials having really just T2s or T3s. But the Everest trial is hopefully coming out finally. Source just reported recently. The Everest mTOR trial, we're hopefully expecting data in the next year. But the S-TRAC trial, we can call it the only hint of success. And this was a trial looking at high-risk clear cell, mostly done in Europe. We did have this open at UCLA and enrolled some patients on this. But these patients got 50 of Sutent, 50 milligrams. And unlike the other trials where they were allowed to dose reduce, we do know that patients on adjuvant therapy have really don't tolerate the agent very well, these agents well, when they're in the adjuvant setting. These patients really were not allowed to dose reduce. And the next slide, really the metric in a lot of these trials is disease-free survival. And this did show there was a improvement in disease-free survival, but how do you explain that to a patient? It's very different than saying, you want to live longer, which really is overall survival. This is recurrence, metastasis, or even cancer death or a secondary cancer all count as in the disease-free survival. And there was an improvement in about a year. Unfortunately, when you look at the overall survival, these curves are completely overlapping, and it's not expected that they will change at all. And this was FDA approved, but really it's used very, very infrequently, and our current guidelines really don't recommend this. It is an option to be discussed, but we do not really allow, we do not put patients on this at our center, and most centers feel the same way. So we have room for improvement, and really the past year to two, we've had lots of excitement in this space. We have multiple trials now to take some of these new FDA-approved checkpoint inhibitors, and can we move them up earlier? And the Emotion and Keynote trials are now fully accrued. We anticipate the results in the next year or two. And can we start integrating some of these systemic agents earlier in our disease? These are PD-1 or PD-L1 monotherapy. These agents are pretty well tolerated. Again, we're seeing them now in the earlier stages of bladder cancer with the approval of Pembro for non-muscle invasive bladder cancer. So, this is something where urologists could play a role in administering some of these agents. The Checkmate 914 study is actually just amended. Now, nivolumab and ipilimumab, there's a little bit increased toxicity there, about 20 to 30% of patients who have dual checkpoint IO, two checkpoint agents together, a little bit more toxicity. So they've amended this to now allow a nivolumab only arm, so the accrual is actually much higher. I'll pay attention to the Prosper study. This is really the only study which is giving some of these agents first. We'll talk about the workflow issue, but it also allows any patients who have a non-clear cell histology to participate. All these trials are looking at improvement in disease-free survival or recurrence-free survival, which again, if they do show that they're positive, again, I think we'll look at the secondary endpoint as well to see whether, it could be FDA approved, but whether it will be adopted is another question. So the Prosper study, which right now is about 530, we have another 230 patients to go, and we hope the urology community would push it forward, is giving patients with T2 or greater kidney tumors, meaning 7 centimeters or greater, or someone who maybe with a T3 clinically, a thrombus, or maybe invasion into the fat, they'll be randomized to resection versus a little alternative workflow where a urologist might be the one to either get the biopsy done before, give a dose or have their colleague give a dose of immune therapy, then do surgery, and then give a patient monthly nivolumab doses. So this is a different workflow for urologists that are not used to really having medical oncologists see patients first. But if urologists are on this kind of in the space, they could potentially learn to do this as well. Next, really, well, these agents can be given safely when the tumor is in place. The question is, can we start giving these therapies in patients who are going to get surgery? Well, the new systemic agents in the early 2000s, like Sutent, sorafenib, they started to be introduced, and we started to see there were some responses. In the IL-2 interferon alpha, the primary tumor never responded, which led to the paradigm where patients should be given surgery up front, and then they should have medication second. So we started to see some of these things. We outlined a nice series early in the experience where we looked at the thrombus shrinking. We call that like a medical angioinfarction. Seeing that maybe tumors would shrink and you'd be able to do nephron sparing surgery, or potentially maybe allow patients to have laparoscopic surgery when they weren't a candidate before, or look at like a litmus test. So urologists can't really allow patients to just see them in a vacuum. We need to understand their other practitioners available, and we'd be able to potentially work with them to help provide really outstanding care. The next approach is patients who have their primary tumor in place, and we want to give some systemic agents such as prior to cytoreductive nephrectomy. We've learned that the primary tumor can shrink, and it is that litmus test, and patients do have reduction in tumor size by up to maybe 10, 20, 30%. The response rate may only be about 10% if you look at RESIST. But these patients that are now in the more localized setting, they might be less heterogeneous, they might have better responses, and we do notice that these patients may have even better responses. Okay, well, we started to integrate these therapies earlier in the disease. And again, there are some patients with localized tumors where you might say, can we give some of these agents, and will it allow patients that were not resectable to be resectable? So we do have patients who were put on trials with like a neoadjuvant or surgical a challenge approach, where we would give patients some of these medications first. Agents such as Pazopanib or Axitinib, which are pretty well tolerated tyrosine kinase inhibitors, have been given either by urologists or with their medical oncologists working together to see maybe we could give these agents that would be helpful to maybe shrink or facilitate surgery. So this is one trial from Brian Reaney and the team at Cleveland Clinic, where they gave patients Pazopanib, and these are a lot of patients where partial nephrectomy was not deemed feasible, had solitary kidneys, had really bad chronic kidney disease, and as you see, the majority of patients have responses. We also see that the RESIST response rate might be lower, but there are lots of patients with 10, 20, 30% shrinkage. And the renal score, the nephrometry score, does show that these tumors do shrink. We do see that with agents such as axitinib, this is from MD Anderson, that these tumors also do have significant shrinkage. Again, the response rate here is, pretty high. If you look at that 30% response as a threshold, and tumors do shrink. Sometimes it's enough to change responses. Again, this is not something which is now considered really a standard approach, but these agents are approved for even unresectable tumors where, resection's in the eye of the beholder. So it can be an option. Now, a lot has changed in how we evaluate patients with even metastatic disease, and the paradigms have really shifted, and it really is important for our urology community to work very closely with our medical oncologist. And this approach has changed since the 1980s when we did we saw a patient with metastatic disease, we would potentially evaluate them and then just take them to surgery. Back then, interferon alpha was the only effective treatment. It's still not FDA, it was never FDA approved, but it was given. And these cytokines were able to produce pretty good responses in patients, but the primary tumor never shrunk. So we did see that when we removed the primary tumor, about 1 to 2% of people would have reduction or disappearance of their distant disease. So if you can remove the primary tumor and have a systemic response in the absence of any effective therapy, it made sense. And the two trials which really reinforced this were the SWOG and EORTC trials, which were identical, and they showed really a significant improvement in overall survival from maybe 7 to 17 months in one trial and 8 to 13 months in the other trial. But we did learn a lot, and my mentor, Ari Beldegren, who would do surgery on almost everyone in that era, I was able to learn that there are patients surgery was just not a good option on. And in patients who are poor candidates for surgery, clearly are going to do poorly. It doesn't matter what era you're in, but a lot of these patients who had either sarcomatoid histology, when they have an explosive disease, or maybe those who have really poor performance status, they don't do well. When they have advanced disease, when they are in need of systemic therapy, which could be delayed, if they go to surgery, then they have any complications, a lot of them will just progress. And by the time you are able to give them medications, they may no longer be candidates. So, back in the era when we didn't have good systemic agents and we didn't have any other options, yes, it was acceptable. You would maybe take them to surgery, but having an upfront surgery approach now, when your median survival, without any systemic agents, which is surgery, is maybe 5 months in the sarcomatoid group, or maybe 6 months in patients with poor performance status, you really learned a lot. So really, urologists should be comprehensively evaluating the patient, understanding basically some ideas of who's a good candidate based on their tumor size, look at their risk status for their overall metastatic burden, such as things like performance status, and as a team decide who should go to surgery. And that would be based on some factors such as their IMDC or the MD Anderson cytoreductive nephrectomy comprehensive overview, where you can basically try to understand who's going to do poorly with an upfront surgery approach. Now, can we give these agents upfront to basically give a litmus test? So the group from the UK with Tom Powell's, he was able to put together 2 nice series with agents such as Sutent or Pazopanib, where patients would be given systemic therapy, and then if they did well, they would go to surgery. These are both trials that patients had about 12 to 16 weeks of systemic therapies. They had a washout. We did see that in patients who had this approach, really 60 to 70% still were able to go to surgery with a short course of systemic therapy. There were patients who did progress, and again, if Sutent or Pazopanib were not able to hold your systemic disease stable, you really would question whether someone would really benefit. Again, these are small studies. They were only single armed, but we did see that patients with poor risk disease, they do poorly when they go with an upfront approach, because a lot of them just blow through therapy, and only about 40% of them are able to make it to surgery, and they have really poor survival, meaning they have those poor risk patients live less than a year. And you potentially would not want that patient to be recovering for half of that year from a surgery where they might have a complication. So the only really trial to look at this timing of cytoreductive nephrectomy was called the SURTIME trial. And this was led by Axel Becks from the Netherlands. And he really had a very selective population, patients with a good performance status. They filled this, what we call the MD Anderson criteria, where we had really a very little low high risk features. And they try to see whether you can give someone 3 cycles of Sutent and then go to surgery, or do surgery and then go when they recover to Sutent. This trial did not accrue well, and the trial was changed. Rather than looking at like PFS, progression-free survival, they did a landmark endpoint to see if the progression-free rate at a certain number of months, 4 months, would actually be different by each approach. We did see that that there was no difference in that progression-free rate. Again, it was a small study. But what's very provocative is that the secondary endpoint, which is underpowered, patients who would have a deferred approach, meaning the patients who did not go right to surgery, who had Sutent, and then the select group, a majority of them did go to surgery here, they did remarkably well. Okay, is this because they, Sutent does something different to the primary tumor? No, it's probably that we just eliminated harming the group of patients who were destined to rapidly progress. We're able to get those group of patients on therapy, then maybe do a delayed surgery, and then they'd be eligible for other lines of therapy down the road. So this was very thought provocative. Again, small, the rate of complications didn't appear too problematic. That progression-free rate was not really important or different, but that overall survival really was pretty provocative. And it really shows that probably deferring cytoreductive nephrectomy may be potential to maybe weed out some of those bad actors that could potentially go on to second-line therapy rather than just progress after surgery and not even get first-line therapy. Now, the elephant in the room for all urologists is really this study which came out now about 2-3 years ago, the Carmina study. This was a large study where they looked at patients with de novo metastatic disease, a little less selective. When we evaluate these patients for cytoreductive nephrectomy, we want to see that they have low burden of disease, they have good performance status, they're not highly symptomatic from a distant metastasis. This really took a lot of all comers, and it was done at about 79 centers, which most of them being very low volume centers. And it did look to see in these patients with clear cell kidney cancer, whether they should have nephrectomy followed by Sutent, or should they just get rid of this idea of nephrectomy being important and just go to Sutent. So again, this really shows that, this was a group of patients who really was not very tightly selected for. And as you see from the trial results on the graph, the patients overall did poorly. The median survival was about 13 months for both groups, maybe about 11 versus 12 versus 13 and a half months. Really, they did very poorly overall, which is much lower than what we see in very well selected cohorts from all our other trials. But what you do see in this cohort is that there are about 45% of patients with poor risk disease. These tumors were large, 8 centimeter median, but the median burden of disease, 14 centimeters, that's a lot. That's maybe 14 1 centimeter lung mets, a median, and it's clearly concerning that those patients are not really significantly being debulked. It's very different than our EORTC or SWOG trials or a lot of these other trials where we were very selective at trying to debulk like 80 to 90% of the disease. So it's not surprising this study shows that in poor surgical candidates, patients do poorly. Really, but the idea here is that you really should not be operating in a vacuum. You should have a really multidisciplinary conversation and decide who may do better with surgery second. Now we have all these new drugs and we have better agents. The role of surgery may change. We have drugs which are now very potent, and in our agents such as Ipi/Nivo, we have a 9% complete response rate. And these agents are very well tolerated. So when we have patients with metastatic disease, we really can say, well, how do these agents work in this setting? Well, we have less issues with rebound. We don't have issues with wound healing like we have with some tyrosine kinase inhibitors. The perioperative morbidity with these agents, at least in the lung and melanoma literature, they're very minimal. You don't have patients who have VEGF TKIs, which potentially can induce some CHF. We don't have any issues such as increased risk of maybe thromboembolic events. but these agents are pretty well tolerated around surgery. They do not appear to be any more harmful. So with the movement of these agents up front and potentially like high complete response rates, how are they going to work in our cytoreductive algorithm now? Well, what's very interesting so far is that we have patients who do really well. And as an example, I have a patient next week, we're doing a cytoreductive nephrectomy on her. She had sarcomatoid histology. All her lung mets have now disappeared, but she still has a big primary tumor in place, which has shrunk from 11 centimeters to 8 centimeters. And we're taking her to surgery. Someone like that never would have been operated on in the past, as she had sarcomatoid disease with invasion into the liver. And now things are dramatically different. Now, these agents have been looked at in several trials. This is one example from my colleagues at MD Anderson, Jose Karam. They looked at different agents and they were trying to see, patients undergoing surgery or metastatectomy after these agents. There are responses, very rare, maybe 2 or 3%. There may be some complete responses in that primary tumor, which is really interesting, but the tumor does not really disappear. Now, the next trial, which we'll see, this is now fully activated. This is a SWOG study led by Hyung Kim and Ulka Veshkampayam at Michigan. And other members of the renal team, SWOG, myself, and Monty Paul. We are basically taking patients who have metastatic RCC. They're going to be given Ipi/Nivo upfront for 4 doses. Now it's an amendment to allow patients to also get axitinib pembrolizumab or avelumab axitinib. After the sweet spot of 12 to 24 weeks, patients are randomized to either surgery or just continuing systemic therapy. And we will see whether patients actually benefit from cytoreductive nephrectomy in this era. And we'll actually have some good level 1 data. Similar study design is being done. It's called the Nordic Sun trial in the Netherlands, and we'll be able to learn more. So just going to give some case studies of patients where we use some of these agents in a kind of a multidisciplinary type of setting. Is a patient with a 2-centimeter renal mass, an atrophic kidney, a creatinine of 1.7. He was placed on active surveillance on the outside, monitored, was kind of lost to follow for a couple years. He came in with about a 5.5 centimeter tumor, which was a little bit challenging, pretty much completely endophytic on the renal vein, on the collecting system. And someone like this, the nephrology score, depending on how you look at it, maybe 10 or 11. Now, something like that, I would feel more comfortable doing a retro robotic partial. But now, back then, I was, doing more open clamping. But this is clearly something where you can lose this kidney and have complications. And it'd be nice to have it pull away from the vein and the renal and the collecting system. This is a patient who we gave, 12 weeks of axitinib. It's considered off-label. Patient a couple months later was re-imaged, 60% reduction in volume. We talked about ablating it. It looked a little bit more feasible, but I took this patient to surgery, and I do believe it made surgery a little bit easier. The tumor did shrink again by 60% volume, and we did this off clamp. We had a segmental renal vein thrombus, which, if it was in deeper, maybe I would have left that behind. The patient did very well, it was a T3A, and his creatinine didn't really change much. He's now actually 3 years out an NED and with pretty good creatinine. These types of agents, you could think about in these select cases, maybe integrating, whether you, the urologist, feels comfortable giving them, or you want to have a close medical oncologist involved. Obviously, also maybe an interventional radiologist to look at how to manage this. You develop your team, you figure out who to go to, who's your person, on the other line of the phone who you want to call. And the reality is we control these patients. So, if you want to start giving a lot of these agents, your medical oncologist, who's your go-to, colleague, if you're the one sending them all of these patients when they recur, if you want to use some of these agents and they could be, helping you with them, as long as you understand the side effects and really when to call for potentially some assistance, you potentially can start integrating some of these patients. Give you one other patient, a man with a large kidney tumor, 45 years old. This patient had 2 very young children, normal kidney function, and he had a really nasty kidney tumor. And in these young patients, you're going to see non-clear cell histologies very often. This large renal mass here, he had a large pre-caval and interradiocaval node, and then this other interradiocaval node. Someone like this, is not going to do very well with upfront surgery. So can we start giving these agents upfront? Well, kidney cancer, these agents are approved for metastatic kidney cancer. If we deem this guy unresectable, or not really, or not a good candidate, we could have clearly given systemic therapy upfront to this individual. But the other approach is doing some systemic therapy and taking them to surgery. We did randomize this gentleman to the PROSPER study, which again is that EORTC study, 8143, and he was randomized to the neoadjuvant arm. He got a biopsy showing clear cell, was given 2 doses of Nivo. Now it's amended to 1. And he had a midline nephrectomy with a really extensive RP&D. Unfortunately, he had some cholecystitis, and he was on that triglyceride low-fat diet for a while, but finalized. And he actually turned out he had an unclassified tumor, T3A, and he had 10 nodes that are positive. And again, he got the year of nivolumab. And he's now, I think, about 3.5 years out, and he's NED. I haven't seen patients with 10 positive nodes be NED for 3+ years out. So those trials are still ongoing, but I'd have to believe there are a subset of patients where giving these agents, in combination with surgery, is really going to be a game changer for them. So I think right now, the field is changing, and we need to know how to either give these agents ourselves in this perioperative setting, or really work closely with a colleague who's going to be able to support us and work very closely with us. That's it. So I'd like to hand over things to Kelly Stratton. Kelly obviously needs no other introduction, but amazing pedigree, trained at Vanderbilt, Sloan Kettering. He's really been a dynamo at Oklahoma, and really he's pushing the field for urologists to be involved in these agents, and I can't thank him enough for letting me participate. Thanks, Kelly.
Thank you. That's wonderful. I'm going to be giving a talk about multidisciplinary care for bladder cancer. Here are the objectives. So first, we'll set out to look at a multidisciplinary approach to managing bladder cancer, look at the role for neoadjuvant chemotherapy prior to radical cystectomy. We'll also assess the potential for bladder preservation, and then discuss some advanced therapeutics and emerging treatments for metastatic bladder cancer. So looking at the role for multidisciplinary care, before maybe even a year or two ago, multidisciplinary care in bladder cancer really pretty much focused around metastatic bladder cancer. But with new approvals, there are several agents that range from non-muscle invasive all the way to metastatic cancer, where we can work together as a team and provide patients multidisciplinary care. So this is a really exciting time for bladder cancer, and there's several new treatments that we can talk about. We'll just jump right into non-muscle invasive bladder cancer. For patients who are BCG unresponsive, there had not been any new treatments available since valrubicin was approved. And really, that's not a very commonly used agent, with only about 10% of patients experiencing a response to valrubicin. So the KEYNOTE-057 study evaluating pembrolizumab in high-risk non-muscle invasive bladder cancer patients who were unresponsive to BCG and declined cystectomy. There was a cohort A that has reported, which is patients with CIS with or without papillary disease who received pembrolizumab with a primary endpoint of complete response measured at 3 months and then going forward. This study had impressive results with nearly 40% of patients having a complete response at 3 months. And of those, over 50% having a durable complete response. And with 17 months of follow-up, there have been complete response with a median complete response rate of over 12 months. So this is really an incredible opportunity to expand our treatment of patients who previously really had limited options, who didn't want to undergo a radical cystectomy. And so the FDA approved pembrolizumab as a treatment for non-muscle invasive bladder cancer unresponsive to BCG, CIS with or without papillary disease. And more recently, the FDA granted an accelerated approval for a novel 6-weekly dosing regimen, which really fits nicely into our surveillance cystoscopy regimen so that patients would receive 2 treatments in between each evaluation with cystoscopy and cytology. And so, particularly in the COVID era, this regimen has been very convenient for patients who want to avoid trips to the clinic and potential exposures and yet still get treatment for their non-muscle invasive bladder cancer. And this really represents an opportunity to work together, urologists and medical oncologists, in a disease space where generally urologists were the only providers taking care of those patients. The SWOG 1605 study of atezolizumab has also now reported some of their results, particularly patients who had CIS. So this study run by SWOG was looking at single agent atezolizumab in high-risk BCG unresponsive patients with a primary endpoint of complete response at 6 months. So a little higher bar than what atezolizumab had. In this study, 75 patients were treated with CIS, of which 41% had a complete response at 3 months and 26% had a complete response at 6 months. Unfortunately, that 6-month mark, they did not meet their safety endpoint, and so the study was stopped early. However, when you look at the 3-month complete response rate, it was very comparable to what we see with pembrolizumab in the KEYNOTE study for patients with CIS. And so as we continue to get follow-up data, we may see additional reports from this study and potentially additional agents available for non-muscle invasive bladder cancer. Outside of immune therapy, there is a report for a new agent, nadofaragene faradenovec, or Adstiladrin, which is a novel intravesical gene-mediated therapy for non-muscle invasive bladder cancer. This study, which was run by the SUO-CTC as a phase 3 study for BCG unresponsive non-muscle invasive bladder cancer, looked at patients who had CIS and also evaluated for complete response. In this, 53% of patients had a complete response at 3 months, and of those, almost half had a durable response at 12 months. And so this is a potential additional agent that could be available in the future for patients with BCG unresponsive non-muscle invasive bladder cancer. Working together with medical oncologists, we can help treat patients who have non-muscle invasive bladder cancer after BCG. There are some urologists who may be interested in using immune therapy, and certainly that is something that can be explored as well. Now, as we look at muscle invasive bladder cancer, this is a slide taken from the joint AUA, ASCO, ASTRO, and SUO guidelines. And really, that collaborative nature is something that is unique to muscle invasive bladder cancer and really speaks to the importance of considering the multidisciplinary approach. Here's some historical data for patients undergoing cystectomy. And really, it shows us that there is a lot of room for improvement if we were to propose radical cystectomy as a single modality treatment for patients with muscle invasive disease, particularly showing short-term survival in the 40 to 60 range for patients with extravesical or lymph node positive disease, those who may benefit the most from neoadjuvant chemotherapy. And then here is a slide showing the 2 studies that really pinpointed the benefit of neoadjuvant therapy, both the EORTC study and the SWOG study. And so in the EORTC study, there was a significant survival benefit to neoadjuvant chemotherapy, as was the SWOG study. Uniquely, the EORTC study included patients who also received radiation therapy and some patients who received both radiation therapy and surgery. In that group, the patients who received neoadjuvant chemotherapy and surgery did better than the rest. And then in the SWOG study, we see a clinically significant benefit in overall survival. Together, in a meta-analysis, there's a nearly 5% improvement in overall survival at the 5-year mark. And this is something that is really critical to the multidisciplinary approach to bladder cancer, because many of these patients struggle to receive adequate chemotherapy. It's also important to consider adequate surgery and the quality of surgery provided to these patients. So these are studies reporting from the groups on the from the group of patients on the SWOG trial. On the left is Dr. Herr's report evaluating lymph node dissection and survival. You can see that patients who had greater than 10 lymph nodes as a marker of surgical quality had the best 5-year survival rates. And on the right, you see stratification between lymph node dissection and the receipt of neoadjuvant chemotherapy. And those patients who both had neoadjuvant chemotherapy, radical cystectomy, and a pelvic lymph node dissection with greater than 10 lymph nodes had the best 5-year overall survival. That was followed by patients who had radical cystectomy and a quality pelvic lymph node dissection. And then was the patients who had neoadjuvant chemotherapy, cystectomy, and an inadequate pelvic lymph node dissection. And so on this slide, we see that neoadjuvant chemotherapy and quality surgery together provide the best outcomes in patients with muscle-invasive bladder cancer. However, some patients may desire to maintain their bladder and choose quality of life over the potential benefit of radical cystectomy. And what's important is that working together with radiation oncologists, we may be able to provide treatment that is equal to or better than neoadjuvant chemotherapy and radical cystectomy. And so bladder preservation using chemotherapy and radiation therapy may become more common in the muscle-invasive bladder cancer patient population. There are 2 ongoing studies evaluating bladder preservation strategies. The first is the SWOG study 1806, which is comparing concurrent chemoradiation therapy with chemoradiation therapy plus immunotherapy. And in this study, the primary endpoint is bladder intact event-free survival. Uniquely, Alliance is looking at dose-dense gemcitabine and cisplatin in patients who may harbor DNA damage response gene alterations. And so in this population, patients who have susceptibility to chemotherapy are going to be evaluated for bladder preservation. Now we can move on to locally advanced and metastatic bladder cancer. Historically, these patients receive first-line chemotherapy with either dose-dense MVAC or gemcitabine and cisplatin. For those who were cisplatin ineligible, we considered carboplatin. And more recently, with the approval of immunotherapy, we've considered that as a additional treatment for cisplatin ineligible patients. However, recent studies have really challenged the simplified treatment schema of first-line chemotherapy and then second-line immunotherapy. And so there's the potential for patients to undergo treatment with platinum-based chemotherapy followed by switch maintenance therapy involving either avelumab or pembrolizumab. And then those patients who recur on switch maintenance therapy to consider either enfortumab vedotin or erdafitinib if they have the appropriate genetic alterations. So looking at the data for switch maintenance therapy, this is the Javelin 100 study of avelumab following patients who receive chemotherapy for metastatic urothelial carcinoma. And what we see is a significant overall survival benefit in the patients who received avelumab. This is a unique study because historically patients who responded to chemotherapy after 4 to 6 cycles of treatment were then watched until they recurred or had progression of disease. For many patients, the second line therapy was immune therapy. And so by creating a situation where patients would receive chemotherapy and switch maintenance to immune therapy, it really shows the impact and benefit of this treatment in the improved overall survival. Likewise, the Hoosier Oncology Group has performed a study with pembrolizumab using switch maintenance therapy after chemotherapy. And in this group, they also showed a survival benefit. And so together, these two agents are considered as potential options following first-line chemotherapy. For those who progress after chemotherapy and immunotherapy, there are two new agents available. The first we'll look at is enfortumab vedotin, a novel Nectin-4 targeted antibody conjugate using a microtubule disrupting agent, MMAE. Basically, this is like a smart bomb for urothelial carcinoma. In a study evaluating enfortumab vedotin, there was a 44% objective response rate in patients who had previously received treatment with chemotherapy and immune therapy. And so this new treatment is an option for patients potentially after undergoing first-line chemotherapy followed by switch maintenance therapy. For those who have alterations in FGFR2 and 3, there's a consideration for the targeted tyrosine kinase inhibitor, erdafitinib. Again, in a study using erdafitinib in patients who received chemotherapy for metastatic bladder cancer, there was an objective tumor response rate of nearly 40% and a progression-free survival of nearly 5.5 months. And so both of these agents have been approved in patients as treatments after first-line therapy and second-line immune therapy. As we look forward, locally advanced and metastatic bladder cancer, we will know that patients who receive cisplatin therapy and then immune therapy are probably going to be those that do the best. There are certainly challenges with patients who are cisplatin ineligible. Looking at the enfortumab vedotin trial, some of those patients receive carboplatin, and so there's a potential that patients could still receive gemcitabine and carboplatin and then undergo switch maintenance therapy until progression. And so that's something that we can work together with our oncology colleagues to determine the right sequence of treatment and then continue to follow these patients. It is important to note that for patients who are receiving immune therapy, the adverse event profile for these drugs are unique, and maintaining vigilance for these adverse side effects from immune therapy is important regardless of who the provider is. Things like diarrhea or a new cough or fatigue could represent a potential change that is induced by immune therapy for bladder cancer. And so it's imperative that urologists, medical oncologists, and even primary care providers maintain vigilance for these side effects. In conclusion, bladder cancer patients are benefiting from a multidisciplinary approach that includes a growing number of treatment options. There is a potential for an emphasis on quality of life and possible bladder preservation even for patients with muscle-invasive bladder cancer. And the treatment of metastatic bladder cancer continues to change based on new drug approvals. That concludes our talk for tonight. We now have a brief period for questions and answers. I'll have the panelists join us. And if you have any questions, you can type them in our message box.
Hi, Kelly. I'll just mention, I think that there were some questions earlier about really how we optimize germline and genetic sequencing, and I'll just speak momentarily because I know there will be many more questions, but you know, both of these are actually recommended by guidelines agencies, particularly germline genetic sequencing, and it's hard sometimes to integrate these into workflows. And so for germline testing, a lot of times we actually send that testing on patients. We consent them, of course, talking to them about ensuring that their data is kept safe and secure. But we then only have patients who have BRCA1, BRCA2, or other heritable genetic defect mutations syndromes actually meet with our genetic counselor, which can sort of cut down on the overload for genetic counselors. And there are actually chat boxes for the different germline genetic testing companies that can help with this in terms of prostate cancer. I imagine that they're also there for kidney cancer and for other groups as well. So just wanted to put that out there as we wait for other questions to come in.
That's really helpful to know about. If you have a patient who presents with newly discovered metastatic prostate cancer, how are you approaching those patients? What do you think is the first line treatment, the best first line treatment, or how would you decide that? Kelvin, if you have any thoughts about that as well.
I'll defer to Kelvin. What do you think?
Well, some of the first considerations, I just look at the overall health of the patient, their performance status, their age, their preferences, and then I look at burden of disease. And you know, a lot of the data has been stratified according to high volume versus low volume disease. And then cost is an issue. I mean, definitely these second line oral anti-androgens are pretty expensive, and especially in comparison to chemotherapy. So really taking into all of that account, if someone's in good shape, wants to be relatively aggressive with high volume disease, I tend to prefer chemotherapy. Those who may be older or with lower volume disease, or may not even necessarily want to do chemo, then I'm much more favorable for the oral therapies. I will integrate sipuleucel T in men with metastatic CRPC and use that as early as possible, again, to emphasize the importance of the lower PSA indicating earlier stage of disease.
I would agree with that, echo 100% that patient preferences and limitations by finances are probably the most meaningful as we try to make those decisions with patients. And there are many patients who say, I just don't want to take a daily pill for years and years. And so they end up on chemotherapy. Others who have financial constraints and others who just prefer to sort of be really aggressive is how I've heard. But I think that the oral anti-androgens or the androgen receptor directed therapies, so including abiraterone, are absolutely reasonable options, and we talk about those too. So it's really a patient preference, and certainly can be dictated by finances as well.
We hope everyone enjoyed the evening, and we're happy that everybody logged in tonight for this webinar. Thank you again.
Thank you, everyone.
Thank you, Dr. Stratton, for setting this up.
Okay, take care, guys.